So listen, Amanda, I'm very, very glad you came to see me today. It was very, very interesting to speak to you and understand your situation and learn about your life and what has happened to you. And I can really understand how it's been very, very painful for you, some of the episodes that have occurred. And I understand how you became addicted to the opiates, the oxycodone. You were getting it by prescription. You thought that you were doing the right thing. The doctors were prescribing it. And then it got away from you. And you are on buprenorphine now. You're on the film strip, and you seem to be doing well with that. And I understand that the purpose of coming in was that you want to discontinue the buprenorphine now. Is that the idea?
That's right. I feel really set on doing that.
But why? Why do you want to get off of it? Because as I understand it, it has been working for you. It took away the cravings that you had for the oxycodone. You're not using any other opioids or any other illicit drugs. You're functioning well. It's not interfering with your functioning. You're not sedated. You're not high. It's kind of like any other medicine for a chronic disease. Why get off of a drug that's working for you, especially since we discussed the unfortunate high relapse rates that are seen in every study that's ever been done?
Well, it's lots of reasons. I mean, when I went on it, I felt like I wanted to be off it someday, and I am really grateful it helped me. You've helped me. People have helped me, and I'm so glad this med exists. But I got to say, I know it can hurt your liver. I have a boyfriend now. I would like to have a baby. I can't imagine staying on this if I were to get pregnant. You know, this boyfriend knows that I'm on it, but even that makes me uncomfortable. And recently I do still go to the AA meetings in New York City. I've done those before, but it's very strong sense that I shouldn't be on it.
Well, listen, you've raised some really important common issues. Let me take them one at a time.
Okay.
Unfortunately, opioid use disorder, which you have, is a chronic condition. It's like asthma, it's like diabetes, it's like osteoarthritis. There is no cure. There is good treatment and there is remission of the problem, but you can't be cured. The reason that you can't be cured is that we can't get rid of the vulnerability that you have to this problem. And you exhibited that vulnerability when you reported to me that when you initially took the oxycodone, it energized you, you liked it, it made you feel much better. And it wasn't even about pain any longer. It was all about that good feeling it brought you. For most people, when they take an oxycodone, they get nauseous, they get dizzy, they just don't like the way it makes them feel, they throw up, and they don't continue to take it. So just liking them and getting energy from them makes you vulnerable. And I know that you think that the cravings won't come back and that you're doing much better now and you have a boyfriend and you're in New York and all that, but it just doesn't work that way. The cravings are a part of opioid use disorder, and they do come back. Now, you do need to know that buprenorphine, which is what you're taking, is a very safe and effective medication. It does not have any adverse impact on any organ in the body. It doesn't damage the liver, it doesn't damage the heart, it doesn't damage the brain.
What about your teeth?
The teeth. There's been this myth for many, many years about methadone rotting teeth and bones, and that's just a myth as well. What rots teeth particularly is not going to the dentist, not brushing teeth, not flossing, and unfortunately many people with addiction don't have good dental care. And in terms of the bones, that is a myth as well. Methadone does not rot the bones, and certainly buprenorphine doesn't. So the only dangerous part about opioids is overdosing and dying. Other than that, it doesn't have organ damage. Now, compare that to alcohol, tobacco, and cocaine, which are very severe addictions as well. But those substances damage every organ in the body. But opiates do not do that. So we have data now of people being on methadone, which is very similar to buprenorphine, for 50 years, taking it every day. And they're fine in terms of their physical status. They've been studied, and nothing pops out as a damaged organ. So I think you can be assured that staying on buprenorphine will not cause you any physical damage to your body.
So you're saying it's safe, but I just kind of feel like I'm addicted to something else.
Yeah, so this is one of the most important things that we have to talk about, and that is proper terminology and vocabulary. There's a big difference between physical dependence and addiction. You are physically dependent on buprenorphine right now, which means that if you stop taking it, you're going to develop mild withdrawal. But most people are physically dependent on their blood pressure medicine, on their diabetes medicine, on their asthma medicine. If they stop taking those medicines, they're going to get sick. And it's very analogous to your situation with the buprenorphine. But physical dependence does not necessarily equal addiction. You're not addicted to the buprenorphine, and the reason you're not is it's not causing you any harm. It's actually only providing you with benefits. And without harm, there really can't be addiction. Because one of the easiest, simplest definitions of addiction is continuing to do something, a drug or an activity like gambling, despite continued harm. But if there's no harm, there's no addiction. So people who don't know a lot about this and throw words around carelessly, they cause a lot of stigma. They make people feel bad. When you take the buprenorphine, it just makes you feel normal. You don't feel high.
I don't feel high.
You don't feel high. You don't get a buzz from it. And you're not addicted to buprenorphine. It's a chronic medication. You're taking it. It's legal. So that's just bad terminology and incorrect terminology. But I want to get back to the pregnancy issue because you are young and you probably want to have a family. We know now for 50 years that people could be on methadone, women, and be pregnant, and it was safe during the pregnancy, and it was safe for the fetus and when the baby was born, and in follow-up of those babies, nothing bad has been found. They don't have any cognitive dysfunction. There are no congenital defects. So every organization, including the American College of Obstetrics and Gynecology, they recommend people be on methadone and now buprenorphine during pregnancy. So if you were to get pregnant, you would stay on the buprenorphine. There'd be no problem. You could breastfeed while you're on the buprenorphine, and it wouldn't be an issue at all. The baby might need to stay in the hospital for a few extra days, may have some mild withdrawal, which is treatable, and wouldn't turn out to be a long-term problem. So that would also not be a reason to risk a relapse. And as you know, Amanda, today, a relapse with the heroin and the contamination with the fentanyl, and I know you've heard of the carfentanil, which is even more potent, can destroy your whole life. And look at what you've built up here. You've got your own apartment, you've got a boyfriend, you've got a career. I don't know if you want to take that kind of chance. You know, you got to be a gambler. The odds are not with you if you get off the buprenorphine. So my recommendation is to stay on it, find the best dose that works for you, and just take it and don't worry about it. However, I'm here to do whatever you want to do. If you want to talk about tapering off of it, if that's what you have to do, we would do it very slowly, very gradually. We would see how you felt during the taper. We'd go up on the dose if that was required. And if you did come off of it completely, I would still want to see you from time to time, and I would want to monitor you. I still would want to do urine drug tests on you just to be sure, have some objective measurement. And if the craving came back, or if any sense of relapse was coming back, or dysphoria was coming back, we just put you right back on the buprenorphine. And we could do that if you wanted to. I would advise you to just stay on it, keep going with your career and all the things you've done here, and really you've been a very successful patient.
Maybe just one last.
Huh?
One more thing is, you know, I'm thinking, it's not like I'm not worried about relapse. I've certainly relapsed before, and things are going well. It's hard not to hope that it's going to continue to go well. But I kind of just can't get past the stigma kind of for the rest of my life. It feels like anytime I apply for a job or anytime I feel like I'm going to be seen as, you know, an addict.
Yeah. Well, Amanda, this is a very reasonable issue, and it's a real issue. I would say in the years that I've been working in the field, I have seen a gradual improvement in the stigma issue. And certainly buprenorphine is less stigmatized than methadone. With methadone, there really is a very, very serious and considerable problem with stigma. But with buprenorphine, because you don't have to go to a clinic and you can do it in an office-based setting, it is less. But you're right, it's there. Whenever you go to a physician or a dentist, you have to decide whether you tell them or not tell them. But I think things are getting better. I think with all the education and all the media attention to opioid use disorder these days, I think that that's lessening the stigma. And I'll tell you, I'm always here to help you. If you want to bring in your significant others or your mother or whoever you want to bring in, we can do a Addiction 101, a Buprenorphine 101. I can call up your doctors if you want me to, or they can call me and I can explain what's going on to them. I think it's lessened. You're right, it's an issue. You'll have to decide with each episode that occurs, do you disclose, do you not disclose? One of the reasons that the stigma persists is that the people who are doing very well, like you, are the ones who keep it hidden the most. And the people who unfortunately are not doing that well are the ones who are always ready to talk to the newspapers and the TV. And so that's a kind of a public relations problem that we haven't been able to overcome well in the last 50 years. But I'm optimistic. I think things are getting better. These days, I think almost everyone knows somebody who has an opiate problem, either a son or a relative or a cousin. It's just so common right now, particularly with the prescription opioids and now the segue into heroin.